All right, good afternoon, everyone. Welcome to M&M. Today is the conclusion of our pain week. We have three presenters or three guests today. We have Dr. Koniaris, Dr. Lecamp, and Dr. Tawos. And I'm going to turn it over to Dr. Koniaris to introduce the cases.
Hi, everyone. I hope you guys aren't too tired about seeing me this whole week, but it's been quite a fun week, I think, and I hope that you guys got a lot out of it. As you know, we've been following two patients to kind of discuss how pain can be complex, especially in chronic pain. Earlier in the week, you heard about management for chronic pain. Then yesterday we talked about interventions through anesthesia pain, and today we're going to talk about the psychiatric and ethical considerations. So I want to thank my colleagues for joining me today. Dr. Tawos and Lecamp are actually Omeri Tawos, not doctor, sorry. And Jean Lecamp have been really instrumental in kind of discussing these cases. Even though these are cases that I was both involved in and our teams have been involved in, not everyone was involved at the same time, but they bring issues that we need to be cognizant of when we deal with patients with chronic pain. So if you remember, our first lady is an 88-year-old woman with a past medical history of 30 years of chronic pain secondary to osteoarthritis that was very difficult to control and was really affecting her quality of life. She had spinal stenosis. She also had bilateral rotator cuff injury. She lived in an independent living. She had somebody who would help take care of her, but it was really difficult. So she would see her PCP. She saw anesthesia pain, and they did some steroid injections, and she said they worked, but they worked for only about 3 months, and after that, it went away, and she felt like the pain was just as bad, and it wasn't worth keep going back in for more injections. She had been tried on Cymbalta, she had been on Tramadol, and ultimately the pain got so severe that she was started on oxycodone. She ended up writing a letter and taking 60 pills, saying that the pain was too much and that she couldn't deal with it anymore. So she ended up overdosing on the medications that her primary care physician had prescribed for her. She came here, and which is where Palliative Care was first introduced to her case, and spoke with her healthcare power of attorney, who is her son, who was very clear that this is my mother's quality of life and it's not quality of life, so we are not going to do anything to reverse this. And so a lot of ethical issues came up with this. The primary care physician had a lot of personal angst about this, feeling, I think, a little guilt, which I think that sometimes we do feel. I think we feel this all the time, be it with opiates or any other kind of treatment. If something goes wrong in our patient's case, we go through those charts over and over and see, did we miss something? Did we do something to kind of cause this? So there was a little guilt involved in this. And again, the ethical issues. Should we allow this patient to die from this overdose, or should we do everything to try and bring her back, knowing that what we're bringing her back to is quality of life that's very difficult? So that's one issue. The other one is our lady who is 75 years old who has a vasculitis, and she has chronic neuropathic pain in her hands and feet. The pain is so severe, as I told you earlier on in the week, that she feels like she's walking on glass. And what she loves to do is sew. She does these really intricate quilting, which she can't do anymore because of the neuropathy in her fingers. So now we have an issue with pain, again, affecting quality of life, but she's otherwise relatively healthy. She's quite a woman and will make you laugh every single time. I really enjoy her as a patient, but she's very difficult for her primary care physician. She saw anesthesia pain. She was started on every single medication you can think of, Cymbalta, Neurontin, Topamax, Lyrica, like everything under the sun she was tried on, and nothing worked. There was always adverse side effects. And finally, she found a PCP, not here in the Cleveland area, who put her on oxycodone, 30 milligrams, that she was taking every 3 hours around the clock. And that to her was good enough. And she moved here, found a PCP here, and she said, this is my way of doing it, and this is what I'm doing, and you're not going to mess with this regimen. And so I met her when she came in a pain crisis, and we converted her over to methadone. But she was very clear to me the first day I met her. She said, I have control over my body, and when my pain is too much, I am either going to take a plane and fly to Oregon, or I am going to let myself die by not eating. So again, we're having similar issues where people get affected by their quality of life secondary to pain, and where are we from a mental health aspect and where are we from an ethical aspect. So with that, I'm going to introduce Dr. Jean LeCamp, who is our actually medical director of psychiatry. So.
CL.
CL, right.
My chairman would be surprised. All right. Thanks for having me back, and thanks for including me in Pain Week. Can everybody hear me okay? All right. Now, these are the objectives that were created for today, and I'm going to address parts of number 1 and number 4. We're going to talk about pain management and symptom management a bit with regard to psychiatric comorbidities and psychosocial issues, and we're going to talk about some elements of safe and reasonable plans of care. So in real life, if you all think back to your most recent time on call, think about that call night at about 4 in the morning. You're not feeling up to snuff. You're probably not feeling your best. You might be a bit physically limited. Maybe you're tired. Maybe you yourself are achy. Cognitively, you might not be your sharpest. And emotionally, when that pager goes off again, it has equal odds of being answered or being tossed in the corner. It's kind of hard telling. You might be feeling a little edgy. And so if you think about, on an average day for us, what might get us going. Now imagine if you have chronic pain, if you have other psychosocial stressors happening, maybe you also have a depressive illness as well. All these things come down on you. And you might hear some of these types of phrases like, come on, deal with it, you'll be all right. Even if I told you that at 3 in the morning when you're on call, you probably wouldn't believe me. Come on, focus. Why can't you focus on some of these issues? You just have to try harder and concentrate. Seriously, just relax. It's nothing to be worried about. Don't stress out. Sometimes, unfortunately, in an effort to reassure our patients, we might use variations on these phrases. It's really probably not the most helpful thing. So, depression and anxiety are both things that are commonly known to be comorbid with pain issues, whether it's chronic pain or acute pain. We're dealing with chronic pain today. Depression can affect people's perception of pain, for sure. It may affect their medication adherence. Maybe they get to the point where they're so depressed that they're not taking any of their medications. Maybe they only episodically take medications. And depression and pain may have a co-occurrence rate of 30 to 65% in patients who have chronic pain issues. In anxiety, of course, this can affect the perception of pain and also the attribution of pain and sort of, how is the person interpreting this pain? We know that patients who are anxious tend to be a bit more somatic, and so an ache or a pain or a twinge might be over-interpreted. If they have any elements of illness, anxiety disorder, they may also be uncomfortable with any increases in their pain or chronicity of their pain. This also can affect medication adherence. Paradoxically, sometimes patients who are anxious really don't like side effects of medications, and so anything that makes them feel a little unusual, maybe feel a little sleepy, maybe feel a little spacey, that makes them extremely anxious. Co-occurrence in this is not as well studied as it is with depression. Some articles say 20%, some say 70%. Interestingly enough, the higher numbers can be in patients who have panic disorder, where they do have a higher co-occurrence of panic disorder in chronic pain than the average population. Less commonly addressed is psychotic disorder population. Certainly, folks with a psychotic disorder or with cognitive impairment of dementia or delirium are not exempt from having chronic pain issues or any other medical problem, correct? So you may have a patient who has a psychotic illness like schizophrenia who then also has chronic pain. You're now dealing not only with a lot of different medications that are going to be going on, but this person may attribute pain to whole other sources than you're really prepared to deal with. They may be paranoid about somebody directly causing them pain. They may attribute pain to something being in their body that might not actually be there. And again, this may affect their medication adherence. Cognitive impairment is probably the time that we think of medication adherence in terms of the patient being able to understand and manage their meds with the most difficulty. And with cognitive impairment too, it can really affect patients' understanding and conceptualization of their pain. They might forget the explanation that you've given them for their pain. They might forget what medication they just took an hour ago because they're still having some discomfort. Now, we are not going to do a chemical dependency lecture today, but I just did want to give a shout out to the patients who have substance use disorders. So certainly substance use disorders can affect the experience of pain, the reporting of pain. That's where you might come into contact with this, and may affect their medication adherence or over-adherence to their medications. Perhaps they're taking their medications a little bit more frequently than you would hope. And as I'm sure was probably covered earlier on in the week in terms of pathophysiology of pain, there can be a hyperalgesia phenomenon for folks who are overusing pain medications. So we have the famous chicken egg problem, right? Do psychiatric issues affect perception and interpretation of pain, or vice versa? It's both, right? So I'm not here to give you any great solutions. Sorry. Please invite me back another time. Maybe I'll have an answer. But it's definitely a chicken egg phenomenon, and it can be really overwhelming, right? Not only to us, that's what we think about. It's overwhelming to know what to do, but to the patients as well, of course. So psychosocial factors. Now, this is not rocket science, but I want to bring it to you in maybe just a little bit of a different way. And our patients are good examples of many of these things. So, I'm sorry, I'm just getting surprised by my fonts that changed a little bit. So anyway, so families and friends, do your patients have good support at home? Are their relationships positive or negative? And are there changing roles going on over time that is connected to their chronic pain? Maybe mom can't do the same things that she used to do. So not only does that make her frustrated and depressed, but then it means that children have to do more. There's a role shift there. That's a very uncomfortable place to be for a lot of people. And especially in our stoic patients who might be a little advanced in age and not as used to talking about their emotions or their feelings or their interactions with people on a moment-to-moment, posted on Facebook type of a way, they may not talk about this and they may just stew on it for a while. And then it's really negatively affecting not only their quality of life, but their interactions with their loved ones. Support. This is perceived support. Now, some people do have ample friends and family and church members and so forth, but sometimes they don't want to reach out and they don't want to become a, quote, burden on other folks. For housing, of course, we know that it's very important to know if they have safe, stable housing where they can ambulate safely, where if they are having more pain issues, they're able to adapt their home environment. And a lot of times this does not happen. And if you think back to the last initial patient evaluation you did, whether it was an H&P or in your clinic, how many of you asked about, ambulation around your home? Are you able to get upstairs to go to the bathroom? Are you able to get into bed by yourself? Do you have grab bars? Do you have, other obstacles in your home? Are there things that we can do to help you adapt your home? This is really important in chronic pain patients. Employment is self-explanatory. It leads right into finances. Do your patients have sufficient finances and their read insurance? And if not, is this limiting the medication choices and maybe the medication adherence? How many times have we had a patient who said that they were saving or rationing out their medications because they didn't have enough money to get a full prescription, or they didn't want to use their monetary resources in that way? And then, of course, medical involvement, which is why we're all here. So these are the patients. I just picked out a few things that I thought were interesting. I'm not going to belabor it, but in terms of the patient with vasculitis and the small fiber neuropathy, I think it's interesting. She did have a primary care doctor. She had pain management involved. She had never been referred for outpatient psychiatry, and which is fine. Not everybody needs to be referred for outpatient psychiatry. But it is interesting given the fact that she was having what I would say were some significant enough symptoms of depression. She was trialed on meds that did include Cymbalta, and she did, of course, make the statements about going to Oregon and said, in I think the second admission, if she had to go to a nursing home, she was just going to stop eating and allow herself to die. And here she was seen by palliative medicine. The Psych CNS was really instrumental. It was a great example of how to get the Psych CNSs involved in helping your patients and their families to communicate. This was an exact example of what I was talking about before with a role change. The patient asked the psych CNS to help facilitate a conversation between herself and her daughter to talk about how her illness was affecting her and how it was affecting the family. And it was beautifully demonstrated in Carol Ayer's notes. And also pastoral care was involved, which I thought was very important. For our second patient, this is our patient with the pain from osteoarthritis and so forth. She also was seen by her PCP, rheumatologist, pain management. Again, no outpatient psychiatry, despite some pretty pronounced depressive symptoms, I would say. Again, tried on some Volta, so I know people are thinking in the right way, like, oh, this might be a little bit of depression, might be a little bit of pain, let's use this. And she did have her overdose, left very clear instructions for what her family was supposed to do with her belongings and her affairs. And of note, she did have a family history of suicide. Her sister killed herself. This is important to know, right? So when we're asking a family history, not only family medical history, but you might expand that a little bit. You know, anybody in the family have a history of depression, anxiety, suicide? Takes 2 seconds to ask it. It's good to know. And of course, palliative medicine was called right away for that patient, and so were we. We were actually consulted on this patient, and it became very interesting. So we. So we have, thank you to whoever, okay, good. So we do have patients who both have chronic pain, both depressed, and our first patient did have anxiety as well as an outpatient. They both were given Cymbalta. They each had thoughts of suicide. One actually had an attempt. Now, our one family, supportive, very supportive. They were discussing the changes and the role changes that had occurred. Our other family, also very supportive. One son was a POA, another son visited frequently, and with the robust family history, I think it was just interesting to see the family's reaction to the event that happened with their loved one, because it wasn't a secret that her sister had killed herself. I mean, this was nothing that we had to really, it wasn't like pulling teeth to get this information. And I think it's interesting that the family, while they were struck by her attempt, they may not have been as surprised as we all were, frankly. All right, this is totally a side note, and I don't know if you guys look at Gomer blog. It's like the Onion for medical practice. Don't look at it now because you're supposed to be paying attention, but it's funny anyway. All right, so care planning. What are you going to do to actually help take care of your patients when they have chronic pain and depression or anxiety or other psychiatric symptoms? So you guys are going to be first line. Primary care physicians are first line for treating these patients. Always remember the benefit of a good referral to a colleague. So whether it's palliative medicine, whether it's rheumatology, whether it's psychiatry, certainly there's enough there for everybody to contribute and to help with. Certainly when folks are admitted here in the hospital, give us a call if it looks like there's something acutely psychiatric that's contributing to the patient's whole picture. As a primary care doctor for these patients, the key questions you already know. I've challenged you to add a few more in, right? A little bit more about the home, maybe a little bit more about the actual support that the person has, and a little bit more about family history. And sort of talking maybe for a moment about the emotional toll that the chronic pain has taken on the person's life. Because frankly, they may or may not offer that up initially, but they'll talk to you about it if you ask. Also, I did put here a complete med list. It's really helpful to have a whole big med list for yourself when you're seeing your patients. We know that our patients don't always tell us everything that they're taking, and I'm going to comment on one thing about that later. But see as best as you can. If your patients are seeing multiple providers, you might not, the right hand might not know what the left hand is doing. So do your best to try to see if your patients can bring in a med list, or if their family can bring in a med list. Ask what pharmacy they use and call and see what the med list is. Particular high-risk patients in a primary care / palliative medicine chronic pain population, people who have chronic pain, so pain that's unremitting for, depending on your definition, for 6 months or longer, and people who have pain at multiple sites. So if you have pain in your left knee, it may not be as impactful on your whole life and worldview as if you have pain in 2 or more sites. If you do have pain in 2 or more sites, you have almost double the chance of meeting criteria for a mood or anxiety disorder. So I thought that was interesting. I did not know that before. If pain is located in joints, especially lower extremity joints, that can contribute to depression and anxiety, probably related to difficulty with ambulation and just getting yourself around. Daily use of pain medications is another risk factor. Females, You know, it's psychiatry, so we get to say females have a higher risk of something. Folks with limited coping strategies and people with limited support, as we've talked to. Now, some places say that the elderly are at a higher risk, some places say lower. Those of us in middle age, we're cool, we're good to go. We apparently are not as high of a risk, so that's one good news. It's probably a bimodal peak, bimodal distribution. So safe and reasonable care plans, certainly checking for your psych comorbidities, checking the access to care and what medications would be reasonable, coming up with a treatment plan, and then, you know, getting the family involved in the treatment plan too. Maybe if somebody needs to drive your patient to physical therapy appointments or to aquatherapy, if somebody has to make sure that the patient is taking medications appropriately, and then just being mentally flexible enough to get a consult later if you need one, to change medications later if you need to. And then the only thing you should be really afraid of in your whole practice is not checking in ORs on your patient. So I've done lectures with you guys before, and I've had everybody put their hand up. So who has ORs access? Better. Yeah, this is definitely better than the last time I asked that question. So please get ORs access. It shows you the controlled substances that your patient is taking throughout the state of Ohio, and you can add, you know, the bordering states. You can ask it to inquire about those states as well. And if you get an ORS, you are at least guaranteed that you're going to be getting the controlled substance list that your patient has been filling. And we know that this is a problem, you know, for people who are filling benzodiazepines and opiates and taking them together and forgetting how to breathe. So this is really, really critically important. So use the ORS. It's a great resource. Couple of reminders. Not all patients in pain are addicted. Some people need opiates. Also, people who are addicted still deserve pain management. That's just my plug. Like if somebody is shooting heroin on the steps of Lakeside and they fall down and they break their leg, they're probably going to need something for pain. That's probably a separate lecture, but just to put it out there. Cymbalta is not a cure-all. It's not a panacea. For the patient who overdosed on her pain medications, she was taken off of all of her home medications, and we did not restart her Cymbalta. And she was fine with it, and her family was fine with it. And one of my colleagues said, well, why aren't you restarting her Cymbalta? She's depressed. I said, well, she's depressed and she's in pain, and she was taking the Cymbalta, and it clearly wasn't fixing those two things. So it's not a cure-all. It's not a panacea. Also, please watch liver function because it is associated with liver toxicity. Serotonin syndrome matters. Please be vigilant. If any of you are sitting out there and you go, ooh, serotonin syndrome, not exactly sure what that looks like, good. Look it up, learn it, and don't forget about it. Because with the number of patients who are on antidepressant agents, anxiolytic agents like Buspar, and then who get prescribed things like not only just tramadol, which we always think about, but fentanyl patches or morphine, this can contribute to serotonin syndrome, and you want to be very vigilant for that. And then please respect the TCA, right? So not every 80-year-old who can't sleep and has some pain should get 50 of amitriptyline at bedtime, right? It's a little bit more anticholinergic than the elderly brain would like to handle. And so just don't throw them around like Tic Tacs because they are something to be respectful of. SNRIs like Cymbalta and Effexor are sort of the new age TCAs, a little bit better tolerated. And if you ever have a question about it, if your patients come in on these medications, please don't hesitate to ask because we're happy to put some guidance there. All right, I think that is all I've got for you. If you have any questions, or I think Mary's going to start. Oh, yeah.
All right, good afternoon, everyone. I'm Mary Tuos. I'm one of the clinical ethicists here. Please do not be afraid by my JD. I am not an attorney here. I may have the degree, but I practice clinical ethics here at UH. All right, so I'm going to primarily go over the ethical issues that are involved with handling these really complex patients who have not only psychiatric complexities, but also have to deal with complex pain as well. All right, so we all pretty much agree that there is always a duty to treat a patient's pain. Doing that is easy to say, but it's often hard to do when we are seeing these patients, because we always need to think about, what are the supports that these patients have in place? Are they truly coming in because they have pain, or are they addicted to it? That's often the thing that people are concerned with. Oh, are these people just medication-seeking patients? Do they really have true pain that we need to treat? So I'm going to argue that even if a patient seems to be drug-seeking, we should still be trying to treat their pain. Okay? So in these situations, we often have two values that are in conflict. Autonomy, in most of these cases, we're dealing with the patient's autonomy. They're coming in saying that they need pain relief, and also we're dealing with informed consent that's couched in autonomy. For informed consent, patients who actually can provide truly informed consent, they have to be capacitated. In the first two cases that we were talking about, we had patients, the first one, she had attempted to commit suicide, and the other one had said that she was thinking about it. So when we have patients like this, that should trigger in your mind, do these patients truly have the capacity to make informed decisions about their health care? Is it to the point that their pain is so severe that it's now clouding their ability to make good informed decisions for themselves? So that's one value that we have to think about for these patients. And on the other side, we have to talk about and really consider non-maleficence. So failing to treat pain. We always need to be careful with these patients that, do they truly have pain? We don't want to ignore the pain that they are suffering from. We also need to consider, if we don't treat their pain, are we really damaging the patient-physician relationship that we're having with these patients? Because if we are seeming like we don't believe our patients and what they're reporting to us, they're just going to leave. And I think that's actually one of the things that people are really concerned about when we're dealing with these patients. You want to do what's best for them, but sometimes what's best for them is saying no. But we're afraid to say no because we think if we say no to this person, they're just going to leave us and go seek treatment from someone else. While that is something that we need to be concerned about, that should not be our primary motivations with how we handle these patients. The next thing we always think about it as well, that's always in the back of our mind, is opioid abuse. Now that is a term that is thrown around a lot, but how do we know that a patient is truly abusing their medications? We need to actually take the time to have a conversation with them. And I know that that's not a very easy thing to do because we're all under very tight time constraints, but having that open dialogue with patients allows them to really tell us the pain that they're having, the result that is happening in their life, the emotional impact that Dr. LeCamp was saying, that you really need to make sure you're thinking about those things. And you want to also prevent self-harm. So we talked about these patients. One almost committed suicide. One was thinking about committing suicide. We don't want our patients to get so severe in their emotional pain that they feel that their only option is to commit suicide. So we want to prevent all of those things. So now, how do we actually get these two values together? Yes?
I would add another thing in that chart is
Okay.
HCAP scores.
HCAP scores. Yeah, that's one thing that I thought about adding in, but that would take us in a completely different direction. I understand that we have to think about satisfaction scores, thinking of our patients as our customers and how we keep them happy. That's definitely something we have to think about, but let's just focus on that because that's a whole nother lecture that we don't have time for right now. Okay, so we have this pendulum that keeps going back and forth. Back in the 1950s and before then, physicians, they were viewed as gods. I, as a patient, am coming to my physician for help. I am in pain and I need my doctor's help to help treat the pain that I'm in. And so patients willingly let their doctors tell them what they needed to do and left all the decision making up to their physicians. Well, now, through several court cases and just a general change in the way society views the patient-physician relationship, the pendulum has now swung all the way over to just completely dealing with patient autonomy. And now that the pendulum has swung in that direction, unfortunately, the consequence of that has been that whenever a patient comes in and says they want something, we have a tendency to give it to them. Now, I'm not saying that you don't investigate and ask questions before you give them the prescription that they're asking for, but you're more likely to give it to them knowing that when the patients know that, you have to think about HCAP scores, knowing that you have to think about reimbursement and things like that. I mean, this is why the pharmaceutical companies directly market to patients. There is data that backs up the fact that that patients, when they come in asking for a specific medication, they're most likely to get it. So how do we end up back in the middle where we should be, where we do what is medically best for our patient and still respect what the patient has decided for themselves. How do we find that happy medium? So we're going to talk about shared decision making because we want to avoid this. Having the doctor get smacked in the face of this pendulum, that you're completely just ceding all your own medical decision making and turning it over to your patient. Something we definitely want to avoid. Okay, so in order to really foster this shared decision making relationship with our patients, we first want to address their pain, truly acknowledge the pain that they are in. Take an inventory of it. Dr. LeCamp was talking about earlier how some patients, if they have 2 or more joints that are being affected by pain, that they're more likely to have anxiety disorders. Well, if you haven't actually had a conversation with the patient about the type of pain they're having, where they're having it, and what the emotional toll on their life it's taking, you're going to miss all of these things and, in fact, not provide the best care that you can possibly give to your patients. So again, have that deep conversation. Take an inventory and validate the patient's reports of their pain. Next, you want to talk about what are their goals. So one of the patients, she makes very intricate glass workings or artistic glass stuff. If that's something that she wants to return to and be able to regain her capacity to get back to doing those things, that's a goal that you may try to set with her. Of course, making sure that she realizes that not all of her goals can be met. We have to think about making sure that she understands there are some goals that will be realistic and some things that she unfortunately will not be able to return to. You want to be very specific about these things. You want to make sure that you go over what are the acceptable comfort levels of this patient. What type of lifestyle do they live? Thinking about the place where they live. Do they have stairs that they have to go up and down? If they have pain in both their knees, maybe talking with them and letting them know that, having a home with stairs is not really going to be feasible with this next stage of your life. Setting those goals with them and really being very concrete in the type of goals that these patients may have. Talking about their physical functional capacity and the different ways that we can go about addressing their symptom relief. The other thing that we also want to make sure and be careful of is mental clarity. When we're dealing with opioids, there's always concern that some patients, if they take too much of it, they're going to be snowed. They're not going to have the capacity that they had before. So having these conversations with them helps set a baseline so that over time, if you see that there's a change in their capacity, you're able to address it. And in that initial conversation that you have with those patients, letting them know that if there is a sign that their capacity is changing, that you're going to start involving more family members, other physicians involved in their care, and making sure that they're not blindsided by the fact that there's going to be a need for more people involved in their care. Okay. Also, you want to talk about the use of other treatments that could be used concurrently with the use of opioids. You have patients who come in and say, okay, physician, I want this specific medication. Well, letting them know, okay, we're going to see if that's medically appropriate for you, but in conjunction with that, let's try these other methods. Maybe we might try these other methods first before returning to that. So making sure that they are aware of these things so that they're not caught off guard. Okay. Next, we want to make sure that the patient doesn't end up feeling like this. They're alone by themselves, surrounded by a crowd of people who have no involvement in their care. This is one of the reasons why I argue that for this initial conversation, making sure they understand that there are going to be more people involved in their care. In fact, encouraging them to bring a loved one who is supportive and they feel comfortable with discussing the amount of pain that they're in and all their other medical issues, that they're comfortable with having that person involved in those discussions with you as their primary care provider and with other physicians along the way as their care becomes more complex. Discussing the psychosocial needs that the patient the psychosocial needs of the patient. Dr. LeCamp had touched upon a lot of these things before, financial concerns, medical concerns, and also their home care needs. These are just a brief, very brief bit of the psychosocial concerns that the patients may have. Again, touching upon decision-making capacity. As their capacity changes over time, we're going to have more people involved, making sure that patients know and are aware that their capacity itself may change over time, and that more people are going to need to be involved in their care. And also being frank about the possibility that they may become dependent upon opioids, and the fact that abuse may actually occur. I know for a lot of patients, they actually refuse to use opioids because of that concern that they're going to become addicted to it. You need to kind of take the bull by the horns and have a free and open discussion with them about the possibility of it, and how, and really laying out the steps that you're going to take along with them in this shared decision-making relationship of how you guys will try to avoid that from happening, but making sure they understand that opioids may be necessary in order to fully control their pain. Okay? All right, so now let's talk about these really complicated patients. If you have a patient who has come to you and they're already dependent upon opioids, how do we deal with them? So you want to make sure that there are multiple people already involved in their care. And when I say multiple, I don't mean like 14 different people. That they at least have at least one other person, a loved one, another primary, or another long-term provider that they have a trusting relationship with, and that can come in and really help go over the amount of pain that the patient is in, to really talk about the benefits that the patient has gotten from the use of the opioids that they've had so far, and any burdens that it has caused, like if there has been a decline in their capacity, if there has been a decline in their ability for the patient to take care of themselves at home, if it has caused other issues like constipation and any of those other risks. That there really is more perspectives involved with taking an inventory of how this patient has gotten to the point where they are right now. If there is a patient who has a history of opioid abuse, you don't want to automatically just take them off of opioids. You want to slowly taper them off. I believe that's one of the recommendations some people have with dealing with these type of patients. You, of course, want to also do a bit more closer follow-up for these patients. Because you know they already have a history of it, or that they are currently abusing opioids, you want to still talk with them about, okay, let's talk about the real problem that you have right now. How do we deal with this problem so that it's no longer a problem for you? Again, having multiple people involved in this discussion will really make sure that the patient feels supported in not only addressing the problem they have, but making sure we come up with a good overall plan of care for them as they continue in the rest of their life. Now, getting to the patients that are psychiatric complex. So for these patients, we want to, of course, make sure they have capacity to be involved in their decision making. If they do not, hopefully they have a surrogate who does have the capacity to be involved and knows the patient well to make good decisions for them on their behalf. You want to make sure that they are fully aware of all the medical issues, both medical and psychiatric, so that they are also fully informed and can make good medical decisions for these patients. You, of course, want to also have close follow-up because you want to be mindful of any drug interactions that's possible. And you also want to let people know that there may be a need for referral to a specialty care setting. Really, the key point is that you have full disclosure with these patients and their loved ones so that everyone is involved and does not get caught off guard by any of the things that may need to be added on to fully care for the patient. All right. This is a table that gives good guidelines on how to deal with these type of patients, these psychiatrically and pain complex patients. I found it in the Journal of Pain from Sullivan and Farrell, and I found that it was a really good guide to help all of you physicians in the discussions that you'll need to have with these patients. All right, I just wanted to end on that note. Hopefully all of you will find this to be very helpful. Thank you all.
So just to kind of finalize things, our one patient with a suicide note ended up recovering actually pretty well on her own, even though we didn't do anything for her, as the family didn't want us to do anything for her. And she ended up going home with hospice, and she died about a week later on hospice services. So that was that patient. Our other patient is now in very high doses of methadone, doses that should not be catered for by a PCP, and she and I had a long conversation about it because I was very worried. about where we were heading. Methadone has a lot of side effects. The QT prolongation is something that we need to be very mindful of. And I said to her, I said, there is a very big risk that you could suffer a cardiac event secondary to this medication. And she said, well, my quality of life is dependent on it, and I'm willing to take that risk. So one of the things that we need to do in all of these cases, and you need to be mindful of, and I think I've brought it up already on Tuesday, is that you need to document everything. I mean, this is the way you protect yourself, is to really be vigilant on how you document. So this was documented. And in terms of her psychiatric aspect, there's a load of underlying psychiatric stuff with her. One of them being that she had 2 abusive marriages. She has a child with longstanding mental illness that she feels that she is responsible for, and what is going to happen if she dies, and what, all of these issues. And the fact that even though psych has been brought up many times, she vehemently refuses to be seen by psych, though the psych CNAs she has brought in. So these are 2 interesting patients that do have a lot of different complexities, and just to remind you that you need to remember that there are a lot of different resources for you out there. There is psych, there is ethics if you have a question. So like, for example, the primary care doc for the woman who overdosed said, well, we have to treat her, we can't let her. And so, we got this consult in the ER, and the woman was obtunded, and I said, what we can't do anything for this patient right now, but what I could do was for the family. And so I spent a lot of time on the phone with the patient's sons, one of whom is a psychologist, actually, and we had long conversations on the phone. They didn't come in at that point, but they were very clear. Our mother has been very clear about this, and she doesn't want any of this. So why should we get in her way? And so I called Omeri, and we spoke about it and said, are we ethically doing the right thing for her? And so it's important that we reach out to everyone to make sure that everyone is involved, and therefore ensure that we're making the right decision for our patients. It may not be the one that we are comfortable with, but it's ultimately what the patient's life. So, any questions? Well, thank you. We welcome any feedback on Pain Week, and if you feel this is something that needs to occur again next week, please let us know, and what particular interests you have that you would like us to cover.
Next year.
Next year, yeah. Okay.
That's why you work on Pain Week.
Okay. No problem.